We talked about the hypothalamic pituitary adrenal axis, so just like anything else, what about diseases here? Really, when cortisol is too high, when cortisol is too low, or adrenocortical hormones, let's say. So Cushing's disease, there's too much cortisol. So what could cause that? Well, the two main causes, it could be an adrenal tumor. If there's an adrenal tumor, it's pumping out tons of cortisol. So cortisol is going to be high, right? So high levels of cortisol, and ACTH in this case, like we talked about how T4 and T3 compare to TSH and hypo and hyperthyroidism. Well, if there's high cortisol, we're going to have more negative feedback on ACTH, and ACTH will be low. But this can differ. So if you have a pituitary tumor pumping out tons of ACTH, well, again, cortisol will be high, but ACTH will be high. But the problem is stemming from a tumor in the anterior pituitary, pumping out tons of ACTH, making cortisol high. Okay? There's a third reason. It could be iatrogenic. Iatrogenic, that word means some kind of treatment caused the problem. Well, what treatment would cause that problem? Steroids, right? Corticosteroids. If you give people tons and tons of prednisone, and they used to have to do that when there wasn't non-steroidal anti-inflammatory drugs and other things like infusions for different inflammatory diseases like rheumatoid arthritis, people would have to stay on prednisone for long periods of time. And when that happened, you could wreak havoc on your body, right? So that is when you actually put an exogenous form of, cortisol, corticosteroid in the body, right? Because cortisol is a steroid hormone. That's why I call them corticosteroids, and that's why NSAIDs, right, non-steroidal anti-inflammatories, didn't take their place, but now we have those drugs which can sometimes mitigate some of the side effects. But we still need corticosteroids. That's getting off topic. Okay, so the things we see in Cushing's disease, so think about what we just talked about with cortisol, we're going to have insulin resistance, right? Why insulin resistance? We're pumping out high levels of cortisol all the time. Remember, hormones, appropriate amount of hormone at the appropriate times. We're dumping tons of cortisol all the time. The liver is going to keep pumping out glucose when it doesn't need to be. Insulin resistance can lead to type 2 diabetes mellitus over time, right? Muscle wasting. Why would there be muscle wasting? Well, I talked about gluconeogenesis. The other process of the liver, cortisol is going to cause non-carbohydrates to turn into carbohydrates, glucose. And a big reservoir that we have in our body, some more than others, is your skeletal muscle. So all these muscles, they're made of proteins. Your body can, depending on the person, but can spare a little bit of protein. You'll break down muscle mass, right? Because cortisol, the other thing to explain here, cortisol is a catabolic hormone. Think of it, there's a ton of it, too much of it, it will break down your body and destroy your body. Think of it like that. So it's releasing glucose, it's breaking down your muscle for gluconeogenesis. You get fat redistribution, a lot because of the insulin resistance. So central obesity, very thin limbs because of the muscle wasting, increased visceral fat production, which we see in insulin resistance. People with certain findings, like get a big round face called a moon face, for lack of a better term. It's what they've called it, a fat deposition of her back. They call a buffalo hump and certain things like that, whether it's appropriate term or not. So those are some of the things we kind of see in Cushing's disease. Now, Addison's disease, this is usually due to an autoimmune destruction of the adrenal cortex, right? So it affects all the adrenal cortical hormones, not just cortisol. There's some other causes, but that's the most common cause. So we have low cortisol, low aldosterone, and we have low DHEA, so the dihydroepiandrosterone, and some of those sex hormones that are made in the zona reticularis. So if you have low cortisol, we tend to get these patients get hypoglycemic, right? They can't maintain their blood glucose, especially really under times of stress. Now we'll learn later, like glucagon's made in the pancreas by the alpha cells. That also goes to the liver. It's also a catabolic hormone and it'll raise your blood glucose. Epinephrine will to some extent as well. So all three of those hormones kind of work together. But if we don't have enough cortisol under times of stress, glucagon's not enough and will become hypoglycemic. Low aldosterone. Well, aldosterone causes increased sodium and water reabsorption. It increases our blood volume, so it maintains our blood pressure. So if we're not holding on to enough sodium and water, well, guess what we're going to have? We're going to have a lower blood volume, and we could have hypotension, right? So hypotension, and then with the zona, and then obviously electrolyte imbalances. If we're not holding enough sodium on, it could be bad enough. You could have hyponatremia. We're not peeing out enough potassium. You could have hyperkalemia, so higher potassium. And then third, with the sex hormones, this doesn't really affect males as much because these are more androgenic type hormones. Obviously, the ovaries are making things like pregnenolone, and then we see progesterone, androstenedione, which converts to testosterone. Testosterone converts to estrogen. But this is still will affect females to some degree, males not as much. But that is something that's involved here. And then Addison's disease, the big findings we see is, I want you to remember, is hypoglycemia and hypotension. There's something called an Addisonian crisis. You put these patients in stress, a major surgery, whatever time they need cortisol to increase, and that's what happens. Okay, so how do you treat Cushing's disease? Well, if there's an adrenal tumor, you remove the tumor. If there's a pituitary tumor, you remove the tumor. If they've been on prednisone for a long time, there's something better you can put them on or lower the dose. But let's say if a patient that had a kidney transplant, they're on immunosuppressive drugs, and they might need a low dose of prednisone, and you have to just, risk versus benefit ratio there, right? And there's also some drugs that block cortisol that could be used. If you can't resect the tumor for some reason, Addison's disease, we replace them, right? All these endocrine diseases we're going to learn. If you have hypothyroidism, you give the patient T4 usually, right? Or T4 and little T3 or Armour thyroid or whatever. So here we got to replace cortisol and aldosterone. So we can use like hydrocortisone to replace the cortisol. And there's a drug called like fludrocortisone that we could use to replace aldosterone, okay? So those are just kind of the basics we're going to see here, okay? And then obviously with adrenocortical insufficiency, we have low amounts of cortisol and aldosterone, so ACTH will tend to be high, okay? And that's pretty much all you need to know.